Welcome. This presentation is going to be about showing you how simple fixed implant dentistry can be. I'm also going to justify the whole entire discipline of implant dentistry for your practice and review all the different parts and pieces that are involved with implant dentistry. I've been performing implant dentistry in my general dental practice for the past 12 years, and it's evolved to a primarily an implant practice, and I'm here to share with you a lot of the tricks, nuances, and just show you how easy and rewarding it could be. There'll be a lot of cases I'm showing you today, and I'll go over a lot of techniques. So I hope you enjoy this presentation, and hope you get a lot out of it. So what I want to do first is cover basically why implants are so important for your dental practice. Then I want to go over some of the terminology and design considerations with implants, because for some clinicians it's a little bit confusing when you start talking about the different cover screws, healing caps, analogs, impression copings. I want to kind of simplify that and really make it real and show you how no matter what system you're using, it really is not complicated at all. And then I'm going to show you a lot of cases and show you how simple that fixed implant dentistry can be. And it's actually easier than performing fixed dentistry on natural teeth. Much easier. I mean, I can do a full arch in the maxilla or the mandible, and the lab is doing most of the work. So I want to convey to you that simplicity. So after I justify it, show you the parts and pieces, and then we'll go into some cases, and I think you're going to enjoy this presentation. This course is created for basically everybody, because if you are doing implants in your practice, I'm hoping to be able to share some nuances with you. If you are not recommending implants in your practice or grafting, you need to follow this, because you should at least be recommending this to your patients, because it is a standard of care to replace missing teeth. And you need to understand the nuances in order to be able to discuss it with them. And if you are currently recommending implants in your practice and grafting, and you're referring those procedures out, you want to understand this so you can really converse with your referral doctors and your patients, as with the first case too. And it's really all about the nuances. And once you really understand and have passion for it, you'll be able to convey it to your patients a lot more clearly. I do want to say that I have used the BioHorizons implant system for the past actually 12 years, and I do see unique advantages to this system. And you know, I am paid by them to speak occasionally, but that's not why I use their system. Someone can't pay me enough to use something that I don't believe in, and I do believe it's one of the better implant systems out there, and I'm going to go into why in a little bit to give you a comparison for other implant systems. And I also speak for and use Da Vinci Dental Studios, and I am their director of implant education, and I found that lab to be quite good over the years. So why are you here today watching this video? Well, the reason is this partial and this full denture and this mandibular denture especially is not the best that we can offer our patients. It's a compromise. This is not the best way to replace missing teeth. And I want to show you a much better alternative. I'm going to show you why, but it's just not good. And this also isn't the best way to replace a missing tooth. You know, if you don't have to grind down adjacent teeth, put stress on these teeth via a ponic or 2 or 3 ponics, which many clinicians do, and it's a compromise to both tooth structure, hygiene, and also if you look at the literature, it's also a compromise to long-term results. A dental implant, and this is a great picture because it really shows how it assimilates a root of a natural tooth. And that's what we're basically trying to do. We're trying to fake nature and replace a natural tooth's root. And this is a life-changing procedure for a patient. And I plan on showing you this in a few minutes. This is a patient of mine who presented with this mess in the upper left. Radiographically, you can see these failing teeth. And I replaced these horrible-looking teeth with dental implants, fixed prosthesis, and I will review the steps involved. And it's really The lab is doing most of the work, and I'll show you that. It's a fairly simple process once you understand all the parts and pieces and what's going on. So I'm going to show you a case like this. And how about a case like this, where a patient presents with this failing bridge as presented? And how do we go from there to here with a fixed prosthesis also? Also life-changing. This is a woman in her early 50s, and she does not have to wear a denture now, which is quite a nice thing to be able to do for a patient. Or how do you take a patient like this, that's edentulous, and give them a fixed bridge like this? I want to review the different parts and pieces involved, the impression techniques, and what's involved in how to do this. There are a lot of questions about performing implant dentistry, treatment planning, going over the patient's medical history, positions of implants, how many implants, what type of implants, the informed consent forms, the provisionalization involved, which is a huge one, because if you don't have a plan, a good plan for provisionalization, that's going to be a problem. Understanding a CAT scan, and you'll see that most every case I do for grafting or implants involves a cone beam CT, because that is a standard of care to plan for implant dentistry. What parts do you order, or what do you stock? What are the steps for provisionalization? So there's a lot involved, and this is why a lot of clinicians kind of shy away from implant dentistry. So I want to kind of alleviate some of these concerns. And if you look in the literature and the journals, there's a lot of nuances involved that can confuse a clinician that gets involved with implant dentistry. So I just want to go over a few cases, and then this lecture will show you the hows and whys as we go along. So a patient presents with missing laterals. You know, what do I do to get there? What implant system do I use? Well, I happen in this case to use, because of the spacing involved, and when I get into the treatment planning module on my website, you'll see why I chose a one-piece implant, and you'll understand why, by having a one-piece implant and not having a micro gap between the abutment and the body, I can actually get closer to a tooth. But these are one-piece 3.0 implants by Horizons, and you can see 6 months later, this young woman has teeth that look like her own. It's quite a nice thing to be able to offer. Or a case like this, where you have an edentulous arch. You know, making a denture and just sucking it up there is really not the best we can offer. But if we can place implants and the right abutments with adequate spacing to give a fixed prosthesis like this, that's certainly something that we could offer the patient that's a much better alternative. Or an edentulous area like this, I would certainly feel, and I think you'll agree, that having some dental implants here spaced accordingly is a better alternative than grinding down teeth and giving a bridge, or certainly a partial denture. And this is a better alternative. What about a ridge that looks like this? Did we just not do implants because there's no bone? Well, if you look at my putties lecture and my grafting lectures, you can see we can transform that ridge and be able to take something like this and just put enough implants in to give a fixed prosthesis. So I'm going to show you how I do these cases and what's involved. Or how do I go from here to here by grafting bone, placing the implant, the right abutment, the right impression copings, and all that. I'm just showing you what's available to take a defect like this, regrow the ridge, and then go through the prosthetic steps. Or a case like this, where there's just a total mess here of bone loss. Look at the bone loss on the three-dimensional CAT scan. Once again, my CAT scan module will cover CTs in depth, but you can see that from a three-dimensional view, there's not a lot of bone here. And then we're going to place, these are healing caps. I'll go over those in a minute. And we're able to restore this patient to full function. So over and over again, to take a gentleman like this, place implants, what are the steps involved? Do you take impressions with natural teeth and implants? How do you time that? These are questions that I'm going to answer for you. The concept of replacing missing teeth has been around for a long time. This is a photo from Ring's textbook showing a mandible from 600 AD with a shell implanted in the jaw. And this patient did not die of this implant. And this was in function. So this concept has been around for many, many years. And over time, we've improved, I feel, if you look here, on the concept of replacing missing teeth. And with Brannemark studies and then ADA provisional acceptance in '86, we've evolved to an industry-wide standard in the mid-90 percentiles of success. NIH Consensus Development Conference in 1988. I often talk to my patients about analogies of other prosthetically replaced things in the body, knees and hips, and dental implants in the literature have a better success rate than these other options. And that's a good way to kind of strike it home. But in order to do this, and once again, I'm starting off with rationalization for the discipline, and I'm just going to zip through this and kind of really hit home as to the importance of implant dentistry. Then I'll get into the parts and pieces, and then I'm going to show you how we tie it together and really show you how simple it is. But in order to make this miracle of recreation of nature work, we need to understand anatomy. We need to understand physiology. We certainly have to understand what biomaterials are involved. Occlusion is extremely important, and I'll show that more when I talk about treatment planning. Pharmacology gets involved in the medical history, and psychology gets involved, as it does with every patient, but from a standpoint with some of these implant cases are quite lengthy. And you want to have a good relationship with the patient and make sure they understand what's going on as far as compliance and the multiple visits. I feel as a clinician doing the surgery that it really helps to understand the histology of what's happening with the bone. Biomechanics are important to avoid prosthetic failures and the different metals and parts and pieces that are involved. And cosmetic dentistry is a big part of this whole implant discipline. Certainly prosthetics are involved. Radiology is involved with diagnosis and treatment planning. And so we have a lot of things that are come into play to really do this well. It's clear from the literature that implants are here to stay. Over and over again, you see this. And you look in JADA, which is a peer-reviewed journal, and over again, you see articles on implants. So we know that implants are here, they're here to stay, and they're not going to go away. So I want to give just a quick analogy. And my friend Scott Gans, who's a prosthodontist, kind of recommended this one day, and I think it's a good one. And basically, I built a new dental office a few years ago. And what you're looking at here did not just pop up overnight. This happened to involve a few years of planning. But the message I want to bring home here is that in order to get to the end result, you need to plan. And building a building is similar to planning for an implant case, especially a large case. So when I built this building, we had floor plans. We had a blueprint. We knew where we were going from the beginning. These are 12 dental operatories with a separate surgical suite with an ICAP machine in the middle, central sterilization, central lab, administration area. This is about a 9,000 square foot floor, but we planned it correctly. Very similar to when I know where I want to go with my implant cases and I plan it with the blueprint of a CAT scan. And I do feel that in order to do a case like this, you need a CAT scan. So here's the blueprint. Similar to this, we have a blueprint. And we have a site plan. This is our site plan here, and our blueprint. And this is my 9-acre piece of property with our parking lots, and everything had to be planned out, just like I do with an implant case. Implant cases need to be planned, and I'll talk more about this when we get into treatment planning. But when you build a building, you have the land that you start with. And this is the 9-acre lot of woods that we started with. This is the land that I start with when I do my surgeries. Land, land. So we take this land and we start doing surgery. And we prepare it. And this is what we're doing here. And by the way, all these trees eventually built a beautiful house for somebody. And then we're also doing surgery. Same thing. We know where we're going, now we're doing surgery to get there. More surgery, we're excavating, we're doing bone grafting, we're building the foundation, just like we do with implants, with grafting. We're building the foundation, we're grafting, we're placing the fixtures. And over time, as we build it and we do a bisque bake try-in, we're trying things in. metal framework, wood framework. And sure enough, in the end, we start to do our glazing, and we have a final product. And this is how things are done anywhere in life, basically. You plan it, you take the steps, and you make it happen. This is my office, now that we're here. It's a teaching facility. We have courses here. This is my upstairs lecture hall. We have a course downstairs for about 50 people. And this is my surgical op. And I teach implant dentistry in my facility in Woodstock, New York. And the courses are listed on my website. So anyway, the message here, it's about planning. And when you plan things well, they work. The good news is that implant dentistry, and I'm once again rationalizing this discipline before I get into the nuances of parts and pieces and simplification. When I first got into implant dentistry, and this was 12 years ago, I thought maybe I missed the boat. Here we are 12 years later, and it's still at its infancy in relative terms. Because people are living longer. And these people have, some of them, have income that could support what's needed, an ideal situation of implants. In your practice, if you decide to really take on implant dentistry from a surgical standpoint, prosthetic standpoint more, whatever, your patients want you to do that. They don't want to be referred out. So the more you can do for your patients, the better. And it's not for every clinician. Not every clinician embraces implant dentistry. Many clinicians would rather embrace ortho or endo. But those that choose implant dentistry, there's certainly a reward there for you. And here's a survey from Dental Products Report stating that 78% of the respondents saw patient inquiries about implants increasing. And we all see that in our practices. We all see that. It's there. And if you look at these stats, 90% of respondents are involved in the restoration or patient education phase of implant dentistry. Now, this is one of the reasons you're here, to understand this better so you can convey this to your patients. Because if you look at your patients and there's any doubt in your eyes as to not understanding something, they're going to feel that. And I'm going to show you some large cases today. And the only way that I could sell, if I want to use that term, to treat patients for these large, expensive cases is to really have a passion for it and an understanding. And I'm trying to convey that to you today. In the country, there's a lot of edentulous people. 10%, according to the NIH, totally edentulous. And I'll show you some more stats in a second. Almost 20% edentulous in one or both arches, not gender specific. If you go to the CDC website, in certain states like New York, 22% over the age of 65 are totally edentulous, no teeth. And then in other states, some of the more financially challenged states, West Virginia and Kentucky, it becomes quite high. In West Virginia, almost 42% of the adults in that state are totally edentulous. And this relates to socioeconomic issues that reflect on our society. There's certainly a lot of work to be done. There's a lot of people also missing just 6 or more teeth. And there's a lot of work to be done to replace teeth that are missing with implants. As I say, it's state dependent, but the CDC website really conveys these stats. And it's sad. This article from the New York Times shows Kentucky's toll of poverty and neglect. And most people have enough trouble putting food on the table than worry about their mouths. It's a sad situation, And it also depends on socioeconomic education issues and different things. But people need to be treated. And the people that want the ideal treatment for missing teeth will gravitate towards dental implants, and you'll see that. What happens when a person is missing teeth is there's a systemic and a physiological and anatomical ramifications and consequences where people can't wear dentures because there's so much bone loss, or there's paresthesia from wearing a denture because it sits on the mental foramen. So a lot of people are missing teeth, and when they do have to wear a denture, there are negative consequences. And there's a decrease in the facial height and the whole face changes. The whole face changes. So missing teeth and edentulosum is not a good thing, and we're here to change that. Bone needs stimulation from teeth or implants. So if a person is missing a tooth, they're going to lose bone. Dentures actually cause bone loss, and this is in the literature. This is JADA, over and over again, where implants will actually stabilize or even stimulate the bone. And this is from a peer-reviewed article in JADA in 1999. Stimulate bone. It's a powerful thing. I'm not climbing down there to fetch your teeth. Serves you right for spitting. This is the wife looking at this. Kind of a macabre joke, but you know, denture jokes are very prevalent on the internet, and they're comical in a way. Dentures are not the best way to replace missing teeth. People that have dentures, 20% of them, according to this article by Mish, don't wear them all the time, or don't wear them at all. 7% are not able to wear their dentures. 88% difficulty with speech. Sorry, Mr. Higgs, but I'm not allowed to chew the meat for you. Meals on wheels. Dentures are somewhat comical. The goal for a clinician is to place implants when there's abundant bone and not have to graft bone to get here. And I talk about grafting in my putty lecture, but you want to be able to stimulate the bone at this point. Sorry to inundate you with denture humor, but they're there. This is the Denture Wearer's Cookbook. Wearing a denture is a life-changing thing in a negative way for a lot of people. I had a patient the other day that was just going on and on how her life has been ruined for the past 2 years since she got her denture. And it fit well. So, you know, when you think about all the social activities involved in our lifestyles around food, you know, all the social activities, the meetings, the picnics, the barbecues, the dinners, you know, when you're wearing a prosthesis that you're afraid is going to come out, that's a problem. This is my favorite: good lungs, bad teeth. When a person wears a denture, there's a systemic aspect to it that's negative. A patient can't chew food that well. You know, less chewing capabilities, according to this Journal of Prosthetic Dentistry article from '78, when a person wears a prosthesis. Lower life expectancy from wearing, having a denture and having compromised dental function because you can't chew food. JADA, 1984. Dementias associated with edentulosum. JADA, once again. Journal of Prosthetic Dentistry. Dentures cause bone loss. Caries, mobility, plaque. So when you have the Journal of Prosthetic Dentistry stating in an article that dentures are negative, you have to think around. You have to think a little bit to think what's a better option. And implants are the answer. There are some disadvantages to implants. There's increased cost involved. There's more appointments. If the surgery isn't done correct, there's the possibility of surgical complications. There's more maintenance involved. But my feeling is these negative consequences, if you want to call them that, are far outweighed by the benefits of it. There's a lot of implant dentistry to be done by us in this country. This article by Mish said basically we're going to be busy for the next many years, 20 years. Every dentist would be doing implants every day. You know, there's a lot of edentulosum. And certainly that's an idealistic perspective, but there is some truth to that. Just real briefly, if you want to look at if a person is missing a tooth, what's the best option? How do you look your patient in the eye and say to them, this is the best option? Well, if you look at the different options that are available, a fixed bridge, a small removable, an acid etched bridge, or an implant, or a fixed partial denture, and you go to the insurance companies, and this is what was done in this article in the Journal of Implantology, over and over again, if you look at the real numbers, an implant offers the best long-term, or a 5-year success rate anyway, above these other options. And when you look at the success rate of, let's say, a removable partial denture there, 83% after 5 years, one of the supporting abutments of the denture was lost. So it is the best option. So I'm done rationalizing it, and I think, you know, obviously you understand it's an important part of implant dentistry, but how do you incorporate this into your practice? Well, you have to believe in it, put educational materials together, have a tight referral team together, educate the staff about implant dentistry, the public, incorporate it into your practice list of services, and invest. So you have to really jump into it. Educate yourself is probably the most important thing, and believing in the value of dental implants also, I feel, is probably one of the most important things that's involved. A lot of clinicians don't get involved with it because they don't understand it. They don't have the knowledge. They're afraid to upset their patients because for years they've been recommending bridges and partials, and it's a paradigm shift, but I think it's time to make that shift. And what you believe in your heart and mind will be transferred to your patients for their choices. When a patient sits in your chair, they have a lot of choices to make. They're thinking about what you're telling them with their teeth, but they're also thinking about their home, their kids, their education for their kids, what they're going to drive, and hopefully it is an R8. But there's a lot going through their mind. And our job as clinicians is to educate them about the possibilities of tooth replacement with implant dentistry and let them make the decision at that point. One thing we can do is offer them financing. And these different companies, CareCredit, Chase Advantage, and Springstone, for example, can really offer your patients some good alternatives to pay this out. When you go to buy a car, they don't expect full payment. Financial options are offered. And that's what these companies do. They do take a percentage of the cost of your fees, but I'll tell you that when you have no accounts receivable over 90 days, it's really a good thing. So our role is to instill the value and quality of life of dental implants. Yes, it all comes down to the quality of life, and inheritance sure would help. More jokes. So how do you sell implant dentistry to your patients? Well, the first thing you do, you want to build trust. You want to explain their present condition, show them its impact on their oral condition and health, show how implants have worked for previous patients. I show them many PowerPoints and successful cases. I convey how predictable and safe the procedure is, and then I leave the room and have my staff review financing. At that point, the patient's either going to a point at that time, or they're going to go home and think about it. So I allow them to digest it. And this is how it works in my practice. I also do quite a bit of marketing. This is one of my implant commercials I have available on my website. That's available to you also to market for your practice. And it's worked well for me, and I recommend marketing as an important part. Website is certainly important. Got to have a good website. And tischlerdental.com is a comprehensive website that really educates the patient, also educates dentists, and I think that's an integral part of a practice. So that is why implant dentistry is important. How, as the clinician now, do you perform this incredible miracle? Well, let's look at this. This is an implant replacing a natural tooth. What's happening here? You need to understand this. Over the years, many different designs have been implemented with implant dentistry. And now we've evolved basically to a screw fixture as the standard of care for implant placement as the surgical option. There are many companies out there. I have stated that I've chosen BioHorizons as my main implant for the past 12 years. And I have reasons for it, but I've also used some of these other companies over the years, and they all work well. There's different nuances about these companies that make them better or worse than others. So these are the parts and pieces involved with an implant. We have the abutment, we have the abutment screw, and we have the body, and then we have this crestal module area. The body is basically the part that's inserted into the bone. And there's different surfaces that are coated on this, whether they be hydroxyapatite, resorbable glass media, roughened up surface, and that's what you want. The bone wants a roughened surface here, and that's what these things do. Titanium is highly biocompatible, and it's the best mechanical and physical compromise to replace a tooth. And that's basically why we use titanium. It's also used in hips and knees. It has the best compromise solution for skeletal tissue replacement because of the biocompatibility, and also because the modulus of elasticity represents the closest to bone or tooth that we have. Basically what happens is the titanium forms an inert oxide layer, and then bone cells somewhat attach to this. I wouldn't say attach as much as grab onto it. and it kind of establishes a contact with the bone. And there's a certain biological width associated with the implant and the tissue. And the important point to know here is that when the fibers attach to an implant, there's only 2 fibers that really attach versus 11 with a natural tooth. So it's not as strong of a bond with the soft tissue. We use threaded implants now because there's increased surface area. In the past, cylinder implants were used. And you can see there's just not enough, not as much surface area for the bone to kind of grab onto here. The body of the implant is coated with various things. Various companies have different processes where they blast it, coat it, and basically the bone wants a the bone wants a roughened surface on this implant to grab onto. I will say that the reason I've used this implant system BioHorizons for the past 12 years is because of the thread design. When you have a square thread, you have increased surface area over a V-shaped thread. You also have the bone in more of a favorable force on it because this is a compressive force put on the bone versus a shear force with an angled thread. It's a nuance, but I like the fact that I have more surface area, and surface area contact with the bone and the implant is certainly the name of the game. If you take the same length implant with a square-shaped thread versus a V-shaped thread, the square-shaped thread offers more surface area. So a 12 millimeter implant, according to the literature, is the equivalent of a probably a 13 or 14 millimeter implant for another company. Now you have to look at design. Now when an implant has a polished area where the bone is, that's not a good thing because the bone does not like a polished surface, and it's going to kind of resorb to get to an area where it's more stable, where it's roughened. So you have to look at implant design and why companies may design this. And you know, when you start to understand what's happening with the implant design, you can make decisions. So that's the implant body. The abutment is the part that screws into the body of the implant, and it supports or retains the prosthesis which sits on the implant. And this is oriented by a hex or another type design, and it's screwed into the implant body. So there's different choices of what you could screw in to the implant body, and I show them here. There's different attachments, and so what's going on here? What are all these about? Well, this really is dependent on what you're doing in the end. And we have stock abutments. We have abutments that are anatomical, that are designed by either casting or scanning. And then there's milled abutments. And so these are choices that you can basically design what goes on that implant depending on the clinical situation. With BioHorizons, one of the advantages of this company is that the abutment actually comes with the implant. And when you're an implant dentist and you're accruing a lot of parts and pieces, that's an advantage from a cost standpoint and also from a spacing standpoint to be able to see what's happening. And oftentimes I just prep the stock abutment and I use the stock abutment in the mouth. You could custom cast an abutment. There are some disadvantages in the literature are that basically you could get porosity, and some claim that it's not as strong as a CAD/CAM milled abutment. But this is a custom abutment. You can see we built a nice emergence profile here. When you could CAD/CAM mill the abutment, you can do this out of zirconia or out of titanium. You get a homogeneous structure that's quite strong. So there are advantages to milled abutments, and you can see that here. So these are just choices that the clinician makes. When you use a stock abutment, you want it prepared correctly so you have a good emergence profile, and you can obtain that if it's prepared correctly. So I use both. One thing you do want to do is take a radiograph of the abutment seated at some point to verify, or the impression coping, to verify that there's no gap here. Because if you have a gap and you take all your impressions, then the whole case will be off. So you want to take a very parallel x-ray there. So that's the abutment. We have the body, the abutment. What about the interface between the two? Well, that interface between the abutment and the implant body could either be an internal design, it could be an external design, it could be an internal tri-channel spline system. So there's different choices. In my practice, I've utilized for the last probably 7 years only an internal design. But there are different choices available, and clinicians choose that accordingly. There is also a one-piece design that, and I showed you earlier, that's attached to the abutments attached to the body. And then there's overdenture. The reason I choose an internal attachment is when I uncover the implant, and I've done this as a two-stage procedure where I've buried the implant and I'm now going to uncover it in 3 or 4 months, it's much easier for me to place the impression coping or the abutment with an internal design because I found in the past when I use the external design that there's bone kind of around this platform and it makes it difficult to seat this. I just find it much easier. The other choice is when I'm doing a two-stage procedure and I'm burying the implant because there's too much prosthetic loading on it or other reasons, there's no half millimeter proud area of the implant sticking up, so I find I get less incision line opening from the tissue. And basically, whatever design there is on the body, this hex design or internal clover is stopping rotation. That's the point of that. When you do a case with multiple implants for a bar, sometimes you'll use a fixture that has no rotational value to it because it doesn't matter. So there's different choices there. But if you look at all the different companies out there, they're all basically doing the same thing, just getting there in different ways. BioHorizons fixtures, one advantage I find is that I use basically the internal tapered implant and the internal straight implant. And one advantage to this combination of these two implants is that all the parts and pieces, the abutment, the cover screws, the healing caps, the analogs, and I'll go over those in a minute, are all the same. So I can basically combine all these parts and pieces with two different implant designs. I find that an advantage in my practice. One of the most important areas of the implant is this crestomodule area where the bone meets the tissue. And this is really where the rubber meets the road because this is where bone is lost. So it's a transitional zone between the body and the gum, and you want to make sure that it's designed correctly so that we don't lose bone there. And you want to avoid this bone loss to the first thread, which does not have to happen. So, for instance, BioHorizons has a laser lock design here. And there's advantages to that because not only does the hard tissue and the soft tissue attach there, because if you're placing an implant on an angled area here, which you often do, it's nice to have a surface that attaches bone and tissue. And that's what this does with the laser lock. Other companies have various designs to help that. If you look at these micro threads on this system, that's certainly an advantage. And so you want to look at this whole interface at the crestomodule area as a talking point and a study point to understand what's happening. You know, don't just do what companies are telling you. Understand it, ask questions. What's happening there? What's happening there? So Noble Biocare has this tie-unite surface, and you know, this looks like a favorable situation, in my opinion. The cover screw is another part. After an implant is placed and you're going to bury it as a two-stage procedure, you want to put something in the body so that tissue doesn't grow in there, and that's what a cover screw does. The other thing that you can place there is a healing cap. But here's a situation where I'm going to bury these implants, and these are cover screws that screw into the body, and then we're going to cover them over. So we use that on a two-stage procedure. Another part you need to understand is the healing cap, also called the permucosal extension. And this is placed when we're going to do this as either a one-stage procedure and leave it uncovered, or after uncovery at stage 2 to leave the tissue so it's going to heal around it. So these are healing caps in a large case, and I'm going to go over cases in just a minute. But there's different heights, different tapered aspects to it, and you can choose that according to the clinical situation. This does help form the emergence profile. And different companies have different variations of it. This is the 3 Eyes encode system that allows the clinician to basically take an impression of this and not have to attach any other parts and pieces, and they actually fabricate an abutment from that. Kind of a neat concept. But this is really the very important part, is how do you transfer what's in the mouth to the lab? Well, you do that via an impression coping, and there's different types of impression copings that are available. And different companies have different variations of that. So what you want to do is you want to basically take either an open tray or a closed tray impression. And I use, with BioHorizons, I'll use their stock abutment with what's called a ball top screw in most of my cases, and you're going to see that in a minute. And I tend to do mostly closed tray impressions, where I'm basically attaching the impression coping, whatever brand it is and whatever it looks like, and then I'm going to basically take a crown and bridge impression. I'm going to pick it up, and then I'm going to attach an analog. You can also do this with an open tray technique, which I find a lot more complicated, and in my practice I really tend to do pretty much only, at this point, closed tray impressions, so I can avoid this extra effort of unscrewing it and all that. Once I take the impression, whether it be closed tray or open tray, I'm then going to attach an analog. And the analog represents the implant in the mouth. So I'm going to go over this in a minute and show you how simple this could really be. These are analogs attached to impression copings. So those are the parts and pieces. These are Noble BioCare's impression copings and analogs. You're going to see the ones I use from BioHorizons are a little bit different, but it doesn't really matter. I just want to convey real quickly that I only cement my crowns. I don't do screw retain prosthetics, and I always split my implants together. This is what I've been taught, and I believe it makes sense. When you splint implants, there's a higher success rate, there's less screw loosening, and less stress to the system, less bone loss. And I also permanently cement my crowns. My philosophy is that micro movement, if that occurs, will cause other macro movement problems and screw breakage. So I always cement my crowns permanently. That's just my choice. Cement retain prosthetics are being phased out more and more by clinicians. And when you screw retain a prosthesis in like this, you have these holes in the top of the crown, which allows for more unstable porcelain here. And also, it allows for more problems with screw breakage according to literature. According to the study, you can see more and more clinicians are using cement retain prosthetics versus screw retain. The trend is definitely going that way. When you cement retain, if there's a casting that's not exactly passive, you get less stress, and there's different reasons why cement retain is better, and these are then published in the literature. One main reason also is that oftentimes the screw is in the exact position that you want the occlusion to be, and that could be a problem when you're trying to get the ideal occlusion. Now, this is a case that was presented to me, a 20-year-old implant case, and it was screw retained, and we have fracturing of the porcelain here. And basically, what I did is I converted this fractured case to a cement retained prosthesis. So I replaced that, and you can see it's just much neater and much more stable. All right, how do we simplify this process? I've rationalized it, and I've shown you the parts and pieces. Now I just want to show you how we really make this simple. So here is an implant that's been placed, and here is a healing cap on that implant. So whether this was a one-stage procedure or it was done as a two-stage procedure and we've uncovered it, now we've waited a few weeks, and here is a healing cap. And I've showed you that a healing cap basically forms this tissue. Well, basically, we're going to unscrew the healing cap, and we're going to attach an impression coping. This happens to be the BioHorizon impression coping. And I'm going to attach this, and I'm going to take a crown and bridge impression. These are retention grooves that have been placed in the abutments, the stock abutments, but if you use another company, there's going to be various retention grooves in it. This is a crown and bridge impression, just like natural teeth. I'm then going to unscrew this impression coping and attach an analog. And I'm going to simply place that into the impression. It's that simple. Now the lab is going to take over and pour this up, make a soft tissue model, and make a final restoration or a provisional. In my office, I often basically do these steps for my referral doctors. And there are reasons, and I can't get into them now, but from a financial standpoint, it's less chair time for a referring clinician if I were to basically prepare the crown for them, the abutment, the crown, and give them the crown to cement. And this is what I do in my practice for my referral doctors. And this is the math that has to do with that. And it really works well. Now, you could also take an open tray impression, which in my practice I do not do. Some clinicians choose to do this. It's more labor intensive. And I find with the system I use, the accuracy that I get, even on a full case like this, is better with a closed tray impression and a lot easier. But it's the same thing. These are the impression copings. And then the soft tissue model is made with the abutments. And these could be prepped stock abutments. These could be custom abutments or a combination of them, which it is in that case. So basically, once the impression is taken, it is now given to the laboratory, whether it be an open tray or a closed tray impression. And the laboratory then prepares the stock abutment or makes a CAD/CAM abutment or cast abutment. The advantage to a lab doing this now with this model is they can survey it, they can create a provisional, and they can allow for the correct contours and contacts, and it's less chair time for the doctor and the patient. The step 3 is the doctor picks up the metal copings. Now, what I do in my practice, is when the laboratory prepares these abutments, and I'm doing a case, and I'll show you this in a minute, I have the laboratory give me metal copings on these abutments. And what I do is I actually, at the second appointment after uncovery, I'm going to deliver these prepared abutments, either stock abutments or CAD/CAM abutments or cast abutments. I'm now going to deliver a provisional and pick up metal copings. And I'll show you this in a minute if it's confusing you. The advantages to me picking up these metal copings is that the patient now gets provisionals at the time of soft tissue healing. When that's done, I can now get feedback from the provisionals, and I can also allow the abutments to be placed permanently at that time. So I'm placing the abutments, and this is especially advantageous in a larger full arch case. And there's different steps involved, and you have different choices when you place implants. So we could either do this as a 1 or 2 stage procedure. We could take an impression at the time of placement. We could place it and immediately load the implant. We could basically do these different options, but at this point, to be able to place the abutments and pick up the metal and deliver a provisional offers definitive advantages. So when would I bury an implant versus not burying an implant as a 1 or 2 stage procedure? Well, I will do this as a 1-stage procedure if it's aesthetically okay to place a healing abutment and there's no functional loading on the implant. So if I could place an abutment in a provisional and there's no occlusion on that and the patient's going to stay away from that for 3 or 4 months, I'm fine with that. If they can't, then I'm going to bury the implant and do it as a 2-stage procedure and then uncover the implant later. So those are the fundamental principles. Those are the parts and pieces. Let me show you in real life what's happening. So a patient presents with this edentulous area up here. And I'm going to basically plan this for a sinus graft. I'm going to take a CT and graft bone and plan it. And then I'm going to place my implants. Okay, so the implants are placed. They've healed. Now this is either, once again, this could have been a 1-stage procedure, which it was, or it could have been a 2-stage procedure where I uncover these implants and now allow the tissue to heal. What am I going to do now? Well, I'm going to now unscrew those healing caps. I'm going to attach an impression coping. This happens to be the BioHorizon impression coping. And I'm going to take a crown and bridge impression. The laboratory now is going to create a soft tissue model. I apologize, but the soft tissue mask is not here. They're also going to create provisionals, and they're going to create a metal framework for me to try in. I'm now going to go to the mouth, and I'm going to attach the abutments. I'm going to attach the metal, and I'm going to pick up the metal. And the advantages now is the patient can give me feedback on the provisionals, which I can convey to the lab. I can allow permanent placement of the abutments, so I don't have to unscrew or screw them on. And I can get feedback for the bite, and I can get a better bite registration. So now the patient now has provisionals. And these are the permanent abutments that I've torqued down. And now the following appointment, I picked up the metal. The laboratory is now going to deliver, put porcelain on the metal, and I'm going to deliver the bridge. And this is what I have. Those are the steps I do, whether it be a small bridge like this or a full arch case. So here's a case where I am replacing a maxillary bridge with a fixed prosthesis. Same steps. So I'm going to basically take a CT after the teeth are removed, and I see that I could, because of the patient's lip line, I could place these implants. There's adequate bone, and my CT module will review that. And I'm now going to place my implants. And here's my 6 fixtures that I placed. The patient's now going to wear a denture. This is a 2-stage procedure. And I'm going to uncover these implants. And I'm going to wait about 2 weeks. And here's what that looks like after uncovery. And these are my healing caps. This happens to be a 5mm tall healing cap. This is a 3mm tall healing cap, depending on the tissue height. So I will now unscrew these. I will attach my impression copings. I will then unscrew those impression copings from the mouth, and I will attach the appropriate analog, whether it be a 4mm implant, a 3mm implant, whatever it is, to that impression coping and place it into the impression. And that's what I'm doing here. The laboratory will then make a soft tissue model, and then I'll do my framework try-in. And in a full arch case like this, they'll give me a wax rim to get the bite in the midline and all that, just like a denture kind of. I'll now pick up this metal. This is the key point. I will pick up the metal. I'll take a bite registration first of the metal. But look how accurate this bite's going to be now, very specific. But I've now torqued down these abutments in a permanent manner. And now I am delivering provisionals. So the patient has gone from here to here. Quite a step. Now I'm able to get feedback from these provisionals, take an impression of them, and guide the lab as to where to go with the permanents. And these are the permanent restorations. And that's what I do. And it's a simple process, and it's repeatable and predictable. And you can do this, as I just showed you, in an area of full arch, or you can do this in an area like this, where once again, take an impression, and I don't always take it at the time of surgery, which I did here, and you can't do that all the time if they're not parallel, but you can, but it's the same process, because now I'm going to have the lab prepare what I just said, the soft tissue model, the metal copings. I'm going to pick up the metal and deliver the provisionals and then the permanent. So over and over again, in every clinical situation, plan the case. You're going to take impressions, go through the different steps here, and I encourage you to look at this chart more carefully because there's a lot to it. But I'm basically taking an impression, attaching the analog, and the lab is doing all the work by preparing the abutments, provisionals, and I'm going to deliver, once again, the final prosthesis and go from there. This happens in my practice on a daily basis, and this is a case where, once again, I'm restoring an entire arch, but it doesn't matter. It's the same steps where I'm taking impressions, delivering, sometimes I'll section the metal, delivering the provisionals, picking up the metal, and then giving the patient the final prosthesis. So I want to end this lecture by kind of stepping back and saying I hoped I have instilled the philosophy of the importance of implants. I hope I've covered the different parts and pieces, and then I hope in the end I've clinically shown you how, through following a protocol of having the laboratory prepare the abutments, deliver, have provisionals created and a metal framework, you can pick that up, get feedback from the provisionals, and really simplify the whole process. My website, tischlerdental.com, has more information on this through articles and courses I offer. And I hope I've educated you. I encourage you to watch this video a few times because I did move a little fast here, but there's a lot of information, but it's good information. And I thank you for watching this, and please contact me via email if you have any questions at all. Thank you very much.